to open up the discussion about it, see what else other people are doing, let you know what we're doing in Sheffield and why. I was approached by the obstetricians because placental invasion is a risk, you know, to mother and baby if not diagnosed before delivery. It's even a risk if it is diagnosed, but at least you've got a chance of improving the outcome. And it's an increasing incidence in the UK. Some of this is accounted for by the increase in caesarean section rate. The Sheffield caesarean section rate is about 25% now, and 10 years ago it was 6%. So we've got a huge increase, and that appears to be happening nationally. And it's very difficult to diagnose confidently. The ultrasonographer that was really good at doing this decided his pension wouldn't be very good if he stayed around, so took early retirement, completely unexpected to all of us, and we lost our experience. Before that, between 1998 and 2009, I'd done 6 patients. And my experience was, well, you might as well toss a coin as do an MR and ask me. It was literally that reliable. And then I'd done 4 patients in 4 months at the end of 2010. And we realised this was a problem and we had to improve. By that stage, there was more in the literature. Other people had had a go, other people were struggling, and there was more data out there for using MR for it. And there was increasing data out for ultrasound. So at the pressure of the obs and gynae staff, we set up a service evaluation. So they were going to ask for this, whatever. They were going to ask me to do it clinically, and they were going to pay for the MR. But what I wanted back in return was complete follow-up. So I wanted all the pathology back, I wanted what happened at surgery, I wanted all the outcome data, I wanted the ultrasound data. And what we did was join forces with the sonographers and set up a pro forma for both of us. So our sonographer's pro forma is not what the obstetricians get on the report. They get a sonographer's report, and the pro forma pushes the sonographers that little bit further to say, do you really think it's invasion or do you really not? But we're not going to take that medically legally, we're not going to hold you account, because we've got some very young sonographers who were just scared of doing that and committing themselves. And that was the problem we found ourselves in, and it looks like it's a problem in a lot of centres. And then to add insult to injury, in January 2011, the Royal College of Obs and Gynae brought out these green top guidelines that said where there's any uncertainty on ultrasound, you just do an MR. Right, based on not a lot it seems. And there was limited experience worldwide. The Australians have been in contact to do a joint study. They're struggling, their incidence has increased, they're being asked to do more MR. So it seems to be something that's hitting everybody. Ultrasound signs of invasion, placenta previa, prominent lacunae, so abnormal colour Doppler imaging patterns, loss of the retroplacental clear space, anomalies at the bladder myometer interface, and uterine bulging. And this is, you normally get a line like that, not quite as wide as that, around the placenta. These are the lacunae that would have increase on Doppler. This is the bladder myometer interface, or placenta bladder interface, and this is a placenta with invasion. MR signs, we did a whole systematic review, pulled out all the papers we could find, and we were left with heterogeneity, dark intraplacental bands and uterine bulging. And that's what we've been basing our reports on, and we've been filling a pro forma as we go along prospectively and collecting the follow-up data. So we sat down. I was, having learned from fetal MR, I wasn't being a sole practitioner for much longer, so I got my gynae radiologist to join me and said, we'll do this together. You can come from your gynae invasion tumour experience, and I'll come from my obstetric experience. We report separately, and then we meet up and co-report. So he wanted his gynae sequences, which gave us this. I wanted my obstetric sequences, which gave us this. And we've tweaked our way through it, cutting our sequences down quite a bit. So we do T2, 5 and 3 millimetres, not always all the 3 millimetres, and we've dropped the coronal section. We don't find it particularly useful because most of the placentas are anterior placed. T1 with a breath hold if possible, and DWI. And the DWI is improving and becoming more useful. I'll show you that as we go on. Our initial scans were very difficult to see the placenta myometer interface. And this is where we got the Fiesta sequence tweak from. We took it from the cardiac sequence, because all I could think of that was equivalent was a dilated left ventricle. So we pulled what we would use for the cardiac sequence, took off the cine element and tweaked it round. And out fell the Fiesta that we've used for all sorts since. And this is a balanced gradient echo type sequence. So it's good for the interface, but it made the placenta completely featureless. Some of the dark lines became light lines, and it was just best for uterine bulging, but it gave us a bit more confidence of what we're looking at. T2 is best for your dark lines. T1's of limited value unless you're going to do looking for bleeds, so we just do T1 in one plane. And the DWI is useful for cases with invasion and bulging. We've actually seen changes. I'm not sure a normal DWI excludes it, but a positive DWI gives you more confidence to say there's definite invasion there. So the problems, and this is where the obstetricians in the audience will laugh at my complete naivety. I assumed naively that the skin caesarean section site was very similar to the uterine caesarean section site. And so did everybody else doing this, actually. I wasn't on my own, but I was quickly corrected. Percreta, if you've got really bad percreta, it's easy. It's all abnormal, it's gross abnormal, you can see it. And I think it's easy on ultrasound as well. Increta is harder to diagnose. And I think accreta, at the moment, I find impossible or exceedingly difficult. It's rather luck than judgment of have you got a bit of accreta there. So percreta, this is your typical placenta. You've got your dark lines within the placenta. You've got bulging of the uterine wall. It's all heterogeneous. It's not the nice uniform colour you'd see of your placenta. And it's the whole placenta that's involved. So we were quite happy that that was a percreta. And again, this is just to show you what happens when you do the balanced gradient tackle or the fiesta. You get your margins beautifully. And you can see the bulging of them, but you've lost your internal detail of the placenta. And we're still tweaking that in the hope that we'll come up with something that shows us smaller amounts of invasion. This is the T1, and again it's very heterogeneous and mottled. It picks up big bleeds. You'd probably pick them up on T2. I'm not really sure the value of it. And this is the DWI, and we can see the placenta on it nicely, and these are the areas where the placenta is actually invaded. And if you see those, that's fine. If you don't see them, I'm not confident to say it's not invaded. And the DWI is improving as we tweak it and get used to it. And this is the pathology specimen. This is all placenta. And this is the uterus itself. This is more of the placenta. The pathology reports we get back for accreta are as about conclusive as my radiology reports. And the pathologists say they really struggle to diagnose accreta, even if they're given it with a section of the uterus. Whereas they're happy with increta and percreta. So I'm not sure radiologically what we're trying to do. This is a case of accreta. We've got an odd little dark band, got odd bit of heterogeneity, no really significant bulging, bladder looks fine, vital loss looks fine, but that was an accreta. And we thought this was probably the area where we might have problems, but the accreta apparently was up there. So I'm not sure in accreta. This is the same case with axial section of it. This is your uterine wall, very thin. And you're not seeing it clearly, but the whole thing wasn't affected. It was a small area of accreta. And the rest of the placenta looks like a normal placenta at this gestational age. We're doing it around between 28 and 32 weeks at the moment. And the obstetricians seem to change their guidelines depending on what the obstetric protocols are. We do get an awful lot presenting at 36 weeks that have not come through for some reason. This is a normal one, which again doesn't look much different to the one I've just shown you, which was an accreta. We've got the normal placental appearance, we've got your normal uterine wall, which, depending where your image is and how you've planned it, it just fades off in all directions because it's so thin anyway, and that's your normal T1. Again, this is a normal posterior placed placenta with an anterior part, and normal placenta. Comes down this area. Can you clearly define where that placenta goes to the uterine wall? So it is very difficult. Localised invasion, I think, will be very difficult. A few more normal cases, you get odd dark lines on a normal one. We reported this as normal. It's been delivered absolutely fine. Other risk factors are previous surgery or abnormalities of the uterus, and this is a patient with adenomatosis of the uterus, and she's got the placenta right over the area that's abnormal, and they want to know, was there any invasion? This is placenta, this is the abnormal uterus. What we relied on here was to say that the placenta itself looked normal, there wasn't any heterogeneity, there weren't any dark bands, we couldn't discuss uterine bulging, but the placenta looked normal. And we had everybody teed up, but it delivered normally, it came away, she was fine. The balanced gradient echo sequence. So this is your placenta, and this is the abnormal area of the uterus. This one, we weren't happy here. This was dark bands, this was heterogeneity, here we got localised invasion. This is the one where I realised I wasn't locating the scar well. There's the scar. And the obstetrician said, oh no, it's down here. So I've moved my goalposts to where the scar is. And what I have discovered when we've chatted to people, other people doing them, that people are using the skin scar as their site to mark where the placenta is most likely to be invaded. So I don't know how many people are doing that and how many people are actually doing where they think the genuine scar is. We reported this as potentially invaded. The dark lines have become light on the balanced gradient echo. This came away perfectly normally at delivery. They were fine, it was a normal placenta. But a week later, she was having a CT for a bit of bleeding, a bit of retake products. And then it's been fine. So there, to me, was that a bit of a filter? Was that a little bit of abnormal area? And was this what we were seeing? Or is localised areas difficult? If this was right the way through the placenta, I'd have happily said it was invaded. But if it's just a localised abnormality, what are we really seeing? So the initial papers, and these are the three really good papers that pull the data together for MR, are probably worth getting out, having a look at if you're doing any of this work. There's good examples in all of them. People actually scribbling, so I'll leave that for there. The more recent stuff that's come out, which I'll put up later, there's a group saying that if you measure the volumes of your dark intraplacental bands, it's different between accreta, increta and percreta, and normal, and they've got 9 patients. So they can only have a maximum of 3 in each group, but they've got some normals as well. So people are looking at it, people are out there struggling to diagnose it, and I think what's coming out now in the literature, and certainly the end of last year, beginning of this year, are small cases that actually aren't going to affect what we do. But we still have this problem of can we do it or can't we? I'm desperately trying to get the sonographers on board and work together. So they do theirs, I do mine. Can we collect all the data in our service evaluation? Can we sit down with the sonographers and the lead obstetrician and work out what the ultrasound would have said, what the MRs would have said? Are they both equally as good? Do we need both? What signs on ultrasound have been prognostic for the diagnosis? What signs on MR? At the moment, our data on MR, if you've got 2 of the 3, the dark bands, the heterogeneity and the bulging, if you've got 2 of the 3, about 80% of them have been diagnosed correctly. If you've got all 3, we're picking up 100% of invasion cases. The most reliable as a single sign on its own is the uterine bulging, irrespective of what's happening to the placenta itself. But like everybody else's cases, we've still got very small numbers. I mean, whether we can set up a multi-centre study with other groups doing it, or what to increase our numbers, but everybody out there is publishing papers on small numbers, and we're just not getting the information. So if anybody else has got any experience, would be interested. If anybody else wants to do any joint work, would be interested. And I think we've got to develop the ultrasound with the MR, and particularly if the college are going to put out guidelines. And then these are the most recent papers. These are very small numbers. The first paper says vascularity in dark bands. The second paper is looking at the volume of dark bands. I think the numbers are too small to actually give anything that's clinically useful. If anybody's got any questions or personal experience they want to share, whether they think that ultrasound, or anybody's got any retrospective data that we might look at.
Hello, thanks for an interesting talk. I'm a sonographer at Cambridge, and I just wondered, what gestation are your sonographers scanning placentas?
They're picked up at the 20-week scan, they're brought back at 28 weeks, okay. And then they're brought back again either side of the MR, depending on who gets the equipment in there first.
Yeah, because we're scanning them about 24 weeks, and having the problems you're discussing, it's really hard to see what's going on.
Well, the obstetricians are asking us to move our scan later so they can do an extra ultrasound in there.
Yeah.
So they're doing the 28-week one, I think, to see if the placenta's moved out of the way and isn't a problem. Well, no, and we thought on MR that it was placenta previa. All our invaded cases have got a full previa. But as soon as you relax into that, comes the one that isn't a previa and is invaded.
I think it's a very interesting topic, and there's some stuff out there that says you diagnose in the first trimester, actually, because what you're looking to see is the various decidual rings and chorionic rings that you get. And the accreta happens because the decidual is denuded at some point, and then the chorion can implant directly onto the myometrium. So some people have shown that you can see this, predict this in the first trimester. The other interesting thing about where the scar is, because if you're scanning in the first trimester, you can see how the gestation sac is implanting relative to the caesarean section scar. The scar is often more visible in the first. The uterus is fairly normal than it was later on. Another thing I would say that in a third of emergency caesarean sections, the caesarean section actually takes place through the cervix, because it's so effaced. So a lot of the times when we're being asked whether there's going to be a creature into that, you should get some history to find out what state of things it may be that the caesarean section isn't actually anywhere where the placenta could possibly implant into. And then my last thing was Bayes' theorem. Because if you put those things together and you find that someone's had more than 2 caesarean sections of over 35, you've got a placenta previa, then they've got a 40% chance of having a creature anyway. So your test is going to be very good if you apply it to them.
I'm very happy to share our experience because I set up a regional service 6 years ago. I think what we've learned from that is that ultrasound is a very good rule-out test. So now we don't MR everybody. Everybody who has a placenta previa and a previous caesarean section scar comes to 2 people. And that's based on the 20-week scan, and we now MR people no later than 28 weeks, because a third of these will present as emergency procedures between 30 and 34 weeks. So if you're leaving it that late, A, I think you run a risk, but B, I don't think your imaging improves. And I suppose as that service has developed, I think what you learn is the really important thing here is actually planning the surgery. And all that's important is not so much about, I know the diagnosis is important because you've got to plan the surgery to diagnose it, but it's really what you're going to do in terms of the surgery. In other words, how are you going to open the uterus? Are you going to go for the placenta? Do you need IR? Do you need stenting? And so, I think the thing that we've learned is that what you then need to do is sit down as a multidisciplinary group post-MR with the ultrasound, the MRI, and the surgeon and the radiologist. I think it's really helpful for us because the guy who does all the IR for these is the guy who does all the diagnostic work. So he learns literally in front of his nose. But I agree with you, it's a learning curve, and it really needs centralising to a very, very small number of people who then actually make the decisions about the surgical approach. Because the problem is that you give this information to other obstetricians, they haven't got a clue what to do with it. It's really about planning the surgery.
And that's what they've asked in Sheffield. Can I say, yes, you need to do a hysterectomy? No, that's normal. And those two are relatively easy compared with this group in the middle. And what they're wanting now to do is to subdivide the group of, do you have the interventional radiologist in there with the lines in, or do you have them hanging around? Can you just have them on site? I think you have to limit. There's a limit to how much we can say, but at least we're able to guide, or we think we're able to guide them.
Yeah, it also entirely depends on parity. Yeah, it depends if you're dealing with a first pregnancy where uterine conservation is of higher importance than somebody who's had 4 caesarean sections. The issue then is not the operation, it's where you open the uterus, because you just couldn't go straight on to it straight. So I think, and I have to say, that's why I raised that to you before. I think in really challenging cases, we, or at least my rate, find gadolinium unbelievably helpful. But I'm interested that people now actually have major. My understanding about that was there was minor concerns about it. At the end of the day, if the risk-benefit ratio is that you may save a woman a hysterectomy or you may do a safe hysterectomy, that balance is probably worth taking. But I really don't know the answer to that. But I don't think there's any doubt about improving the quality of the imaging.
If you've got a previous section with an anterior previa, a lot of people will take the precaution of having available their IR and so on, even in the absence of a strong suspicion of a percreator or increator, because they can still bleed like stink, and you can still end up requiring exactly the same surgical interventions regardless of the localized invasion.
That's the base theory thing again.
Yeah. Yeah.
Certainly in my region, what's happening is that the local hospitals are doing the imaging and sending the imaging into me, so that I can take the blame.
Yeah, interestingly, is what we do locally is even if you have an MRI and are reassured, if we've got an anterior preview with a previous section, we'll still have everything ready on the assumptions we've got IR on site, that we will still go.
In which case your MRI is not actually...
Exactly.
No,
Exactly. It's not
well, that's exactly right. The MR doesn't necessarily do that. And
so
it goes the other way.
Has
Some
someone
people,
challenged the RCOG if they produce this guideline on no strong basis, and for a DT DGH radiologist to get experience in doing these, because they're now being asked to do them, and yet I'm being told that the obstetricians are actually going to have the interventional radiologist on putting catheters in. What I say is, isn't actually going to alter the clinical management.
I think given some more experience, there will be challenge. Would you agree, Steve?
I think we should, all these cases, for the diagnostic purposes, should be regionalised in central unit. One people can get a lot of experience, because it's a high-risk business. If you get it wrong, there's a lot of blood on the floor. And equally, it's people now appreciate that IR's not that safe.
no,
There's been a whole series of case reports and case series now of significant complications from IR. So, I think the default position that we'll just do it under IR just in case, I think
That's not a good
is
position.
No, we have them available under IR.
The trouble is,
They're alerted.
yeah, I mean, the difficulty is that if you make a call, you go for the placenta and you've got it wrong, the length of time it takes you to get IR in these patients will have been 3-4 litres. So, I think that decision is a very, very important decision. And I think everybody has to accept that you're going to get it right sometimes, you're going to get it wrong sometimes. It's just a case of consolidating that experience.
I'd also like to reiterate the use of ultrasound, because sometimes you have inexperienced ultrasound, then you get a placental MR, then actually what really helps is someone who knows what they're looking at on ultrasound and have another look.
Absolutely.
Yeah, and I think what you say about MDT is the way we're going in Sheffield to do it. Okay, we're running a little behind, so we'll see how quick everybody gets through lunch as to what time we restart.